Good day to everyone. And first I would like to thank Charlie letting me represent some of my result of my group in front of such an auditorium. I must admit that I have quoted most of you in my MSc, PhD and papers I wrote, so it's a great honor to be in front of such an auditorium. I have nothing to disclose, and few words as from the fact that I'm a surgeon, I will also share with you some of my thoughts about surgery and recurrence rates. As you can see, and we all know that it's a fibroproliferative disease, and the recurrence rates has been reported from 0 to as high as 77%. That depends on follow-up time. As already stated and quoted also today, it's a matter of time if you live long enough to get a recurrence. And definition of recurrence: secondary contraction, pre- and post-operative range of motion, or total activity. On this picture, I have presented at the bottom results of my study that I have conducted in Croatia, and our follow-up was 7.5 years, and very similar results to the Tibbiana study. And as we see, with the follow-up terms long enough, the recurrence rates grows. Some of the pictures, as I'm surgeon, I would like to share my experience. I went through the Brunner incision at the beginning. They didn't give me enough skin to elongate after the surgery. Then I modified them with VY incision, and I end up with a ziplasty. I use longitudinal incision, close for each finger from 2 to 3 ziplasty. And this is not the most accurate picture. I have lost my data on hard disk. I combine open palm technique with them. I don't suture the transversal. If there is a pointer, I can show you. I don't suture those transversal incision. I use them as a small mini open palm technique to reduce the risk of tip necrosis, to ease the evacuation of possible hematoma, and to ease the post-operative early movement of patient. So, non-surgical treatments are being investigated, and among them drugs with anti-proliferative activity, as we all know that the proliferation is increased in this disease. And the therapeutic potential of newly synthesized cytostatic drugs was thus evaluated for the treatment and/or for the reduction of post-operative recurrence rates. So I won't bother you with the names. We just call them compound 1, 2, 3, and the fourth compound was used as a control one, as you all know that it has good anti-proliferative effect in vitro and in vivo in ophthalmologic surgery. Those three compounds that I have mentioned has been proven to have good anti-proliferative effects, as in this paper, so they were tested for their anti-proliferative activity on the primary fibroblast, myofibroblast cells, cultures derived from the palmar fascia of patients with the disease. As for the materials and the methods, as from the fact that there are only 2 surgeons in my department in Croatia, I'm the one who has collected all samples in all our published papers until now. In this study, we included 8 male patients, 6 primary cases, 2 recurrences, and we marked the samples as D for macroscopically affected tissue, ND, the one that was taken close to the primary incision, but without phenotypic expression, or macroscopically healthy tissue, as Dr. Bayat asked yesterday. Then what I would like to point out, we have found the problems. If there is a first or second stage to Tibbiana, and I know that I bleed fast from the palm to the digit, I remove it in continuity. If there is a stage 3 or 4 and that the operation will last longer, we have seen that if the tissue is too much exposed, you put the cochlear clamp and you manipulate with it, we have difficulties by getting quality cell cultures. So I removed, in that case, in advanced stage, first the tissue from the palm, I handle it, then I remove, I go further on with the dissection in the finger. That's what we have found out. So probably it's a question of vitality of the tissue being too much exposed. And the control samples were marked with the K. They were taken from the patients that were undergone the carpal tunnel syndrome release. And ND was the macroscopically unaffected tissue. The cells were grown according to the standard cell growth procedure. So we marked the 5-FU as a compound 1, and then the compound 2, 3, and 4. Those compounds were synthesized by our scientists, and the compound 3 and 4 are already patented. So as for the results, upon establishment of successful cell cultures from D, ND, and the control eyes, The series of proliferative tests were performed to determine the compound or compounds that exhibit differential antiproliferative activity on the cells derived from Dupuytren patients. As you can all see, it was tested on all 3 compounds in a period of time on 3rd, 6th, and 13th day, and the strongest compound showed to be compound 3, but it has no differential activity on those 3 cell cultures, so it was highly cytotoxic. The one being mostly interesting for us is compound 4, because on each period of time, it has shown to be highly specific for Dupuytren cell lines at those concentrations, preserving the ND and the control cells. At this table, these tests were aimed at determining the IC50 and LC50 values for the testing compound, and to determine the compound or the compounds that will exhibit differential activity between the diseased tissue, that means the tissue marked with the DND, and ND and the control 1K, or alternatively between the tissue taken from the patients, between the macroscopically healthy and affected tissue. And as you can all see, the compound 4 has shown to be highly specific. The effect of those newly synthesized cytostatic drugs was additionally monitored by immunofluorescence compared to the untreated cells and those treated from Dupuytren disease, those treated with all 4 compounds. The green luminescence is in direct correlation with the expression of alpha smooth muscle actin, and as you can see, for the compound 1 to 3, the cell enlargement was taken as a cell arrest. So, drugs with the antiproliferative action may be valuable in Dupuytren treatment. If we assume that the proliferation of cultured fibroblasts is a key process that precedes their change and differentiation in myofibroblasts, which is highly important for arising a symptom in the disease, we tested the antiproliferative activities on the newly synthesized compounds on the cells derived from the Dupuytren patients. We used 5-FU as the control one, as being reported for its good antiproliferative activity in vitro. And as I already shown at the picture, the compound 3 shows to be most potent one, but it was non-specific. This compound showed to be the most cytotoxic among all the compounds. But the most interesting one, and it was compound 4, I won't bother with the name, belonging to the class of compounds that specifically inhibit mammalian topoisomerase activity. It binds to the ctDNA, causing the DNA damage as reported in this article, and also interfere with the tubulin polymerization. So, being highly specific for observed Dupuytren cells, this compound could be interesting for selective treatment of Dupuytren cells at early stages of disease, which is characterized by high proliferation rates. As we all know, in my case, I have sent a specimen to the pathologist. I catch the disease in last one, the residual phase, maybe in the involutional one, but I didn't catch the patients with the proliferative phase. So it should be something to think about when we are going to treat those patients in the early phase of the disease. Also, it could be used in a postoperative application related to the wound healing process, especially due to its low toxicity on all tested cell cultures. So, out of 4 tested substances, compound 4 appears to be the best choice for further preclinical studies and optimization, as it acted in a highly specific manner on the cells derived from diseased fascia taken from the Dupuytren disease patients. And it has a low cytotoxicity effect. For future perspective, it should be clinical investigation for the compound 4 or the new substances. We are all seeking for the drug target. We had pointed out the picture is smaller than it should be, sorry. It's a PEACT signal pathway and ERBB2 and EGF1 receptor. So hopefully in the future we will find something to target the cause.